Good morning, everyone. Now I will be presenting my second case. Thank you, organizers, for giving me this opportunity. So this is a IVS guided Rota PCI in a post-CABG patient, elderly patient, who had now presented with graft failure, and this got complicated by perforation. So I'll be discussing how I manage this particular case. So my patient is a 73-year-old female, non-diabetic, CAD post Cabg 2009. Now she is admitted with chronic stable angina, class 3, and echo showed EF of 45% with mild MR. In ECG, there were ST depression in the inferior lateral leads, and CT angiogram I had taken before proceeding for the angiography, conventional angiography, and which showed patent lemma to LAD and RSVG to RCA were patent, but there were graft to D1 and OM which were excluded. So I took the patient for check angiogram on 19th of January. So this is the angiogram. We can see there is a competitive flow in the LAD. This is a diffuse calcified vessel, and left main is also diseased from the ostium. It's a short left main with the ostial disease and calcification, and competitive flow shows that patent lemma to LAD is there, and diagonal is flowing. So there is a disease in the proximal LAD, but diagonal is flowing. So graft was blocked. So coming to the LCX, ostium to proximal part is 99% diseased, and distal part also has got some disease, 50-70%. OMs are very small. So we know that graft is already occluded. So I took her for the angioplasty of this LCX because I wanted to ensure the patency of this LCX part. So first I took a long sheath because it was a very tortuous artery, so tortuous aorta. So after that I took a 7 French JL guide because I knew that I may have to use Rota for this part. And filter FC crossed with great difficulty with the microcatheter support. So I knew that from begin only no balloon is going to cross. So switch to this chain with Rota wire, and after that started burring with the 1.5 mm burr at 170,000 speed. After around 3 minutes of burring, we could achieve this Rota ablation was successful. So it was crossing now. So this was after Rota. So after this, I exchanged wire with the filter FC again, and still microcatheter is not crossing this part only. So we had to cross with this part, keeping this part. So after that, I started pre-dilating with the 2.5 into 15 balloon, and both the proximal and mid part, the LCX. And after that, only I took the Ivus run, which showed there was a calcification, which was around 360 degree here in the ostial part. Distal part also had quite a bit calcification. We can't know the depth of the calcification, but it was a calcified, hugely calcified vessel post CABG patient. So thereafter, I further dilated with the cutting balloon 2.5 into 12, and from ostial LMC to LCX was done. So after that, I parked a BMW wire in the LAD and started dilating with the bigger balloon, NC balloon, 2.7. I am getting good expansion here of this balloon. And after that, I tried to deliver a long stent, but it could not go. So as expected, because it's a angulated vessel, tortuous vessel, and with huge calcification, wiring was also very difficult. So after this, I took a shorter stent, but that was also not going. So after this, I did the pre-dilatation, and after that again I tried with the same balloon, but it was not going. So smaller stent also was not being, I was not able to deliver. So after that, I used a buddy wire. Still it was not going. So I further dilated with the NC pressure, now at higher pressure. But as we can see, there is eccentric expansion is there. This caused a perforation here. It was small perforation, so immediately with the same balloon, I deployed firstly at low pressure, but it was persisting, and so thereafter I give a pronged balloon tamponade for this. Thereafter it stopped, and then I tried to deliver a covered stent, but it, as expected, it will not go. So thereafter I choose a normal stent, and because I can't deliver a covered stent here, with that I can't jail the LAD. So thereafter, I deployed a normal stent and post-dilated with the stent balloon. And thereafter, I tried to deliver another stent in the distal part. That was not possible, and despite body wire, and so finally I decided to dab this part. So I could achieve, could negotiate the dab 2.5 into 15, and this was the final result after doing this and spending 2.5 hours with this patient. So this was the final result, and it was a flowing LCX, left main to L6, and diagonal was also flowing. So this patient has now completed 6 months of clinical follow-up, and symptomatically she is better. She has to be on anti-anginal drugs, but still symptomatically she is better, and echo at 6 months is showing little improvement in EF is there, 50%. So take-home message from my case is that post-CABG patients are difficult to manage, and they generally have profound calcification. As we have seen in a recent study published in 2021, that calcification is more at the bifurcation as well as at the LCX part, ostial LCX part. Same was seen in this patient. So Ivus guidance helped in deciding this optimal strategy, and Rota ablation is extremely useful for such balloon uncrossable lesions. And however, still stent may be difficult, so we have to choose the other strategies. And smaller perforation generally heals after balloon tamponade, as we have seen in this patient. And optimal results are still not elusive, so we have to achieve the result which, as we know that better is the enemy of the good. So sometimes we have to keep the procedure like that. Thank you, sir.